Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Course and Predictors of Cognitive Function in Prostate Cancer Patients Receiving Androgen Deprivation Therapy, a controlled comparison by Brian D. Gonzalez et al. My name is Susan Slovan, and I am attending physician and member Genitourinary Oncology Service, Sidney Kimmel Center for Prostate and Urologic Cancers, Memorial Sloan Kettering Cancer Center, New York, USA. My oncologic specialty is genitourinary oncology. Androgen deprivation therapy in the neoadjuvant and adjuvant settings with radiation remains a standard of care for patients with high-risk prostate cancer, defined as those newly diagnosed patients with pretreatment PSA of greater than or equal to 20 or Gleason scores of 8, 9, 10, or large bulky prostate. Similarly, it continues to be the first line of therapy for patients with metastatic disease. Not only does it cause a decline in the disease biomarker, prostate-specific antigen, but it can lead to disease regression. Despite its efficacy, patients will report on subtle cognitive changes that may often be dismissed as age rather than drug-related. While the merits of androgen deprivation therapy are great, there has remained significant controversy as to its impact on multiple cognitive parameters. Studies evaluating different cognitive parameters have been contradictory due to their retrospective nature or the lack of longitudinal trial designs permitting a thorough assessment of the impact of androgen deprivation therapy over time. Also lacking was the absence of comparison groups, shorter follow-up intervals for assessment and evaluation using multiple cognitive domains. Several meta-analyses have reviewed conflicting papers in the literature suggesting that patients who received androgen deprivation therapy performed significantly worse on visual motor tasks compared to non-cancer control groups. The conclusion of all these studies remains that patients should be well informed about the benefits and risks of androgen deprivation therapy, but notwithstanding these recommendations, physicians have been remiss in emphasizing the potential effects on cognition. Gonzalez et al. Have attempted to address these issues by evaluating the cognitive functioning of a well-defined cohort of patients over a 12-month period following the initiation of androgen deprivation therapy. This included prostate cancer patients who were not exposed to androgen deprivation therapy, as well as men without a cancer history of similar age and educational level. Men with prostate cancer were further stratified as having either metastatic or no metastatic disease and would receive treatment for at least greater than or equal to 6 months. No prior exposure to hormonal therapy was permitted. Exploratory analyses included genetic variants via single-chain polymorphisms using the Illumina platform, patient age, cognitive reserve, symptomatology as moderators of the impact of androgen deprivation therapy. These parameters were further expanded to include whether genetic inheritance, age, cognitive reserve, depressive symptoms, fatigue, hot flushes, in combination with androgen deprivation therapy would confer a double hit in which recipients of androgen deprivation therapy with at-risk genetic alleles or older age or greater treatment-associated side effects or less cognitive reserve would express the greatest decrements in cognitive functions. Information regarding the effects of androgen deprivation therapy was collected from 2 institutions over a 5-year period. Baseline assessments were completed by patients who went on to androgen deprivation therapy before or within 21 days of starting therapy and 6 and 12 months later. Analyses were restricted to 58 prostate patients on therapy, 84 patients with cancer not on therapy, and 88 cancer-free participants. Genomic DNA for single nucleotide polymorphism selection was performed. Cognitive performance was conducted by clinical psychology graduate students trained and supervised by clinical psychologists. Baseline self-reporting forms included the Center for Epidemiology Studies Depression Scale, the Fatigue Symptom Inventory, and the Hot Flash-Related Daily Interference Scale, all of which are validated and have been used in prostate cancer research. Abnormalities in cognitive performances was defined as scored greater than or equal to 1.5 standard deviations below published norms on a greater than or equal to 2 tests, or scoring greater than or equal to 2 standard deviations below published norms on greater than 1 test in accordance with ICCTF guidelines. A two-sided alpha level of 0.05 was established for its statistical significance. The results of this study showed a higher level of comorbidities in the group treated with hormonal therapy and had higher Gleason scores than the untreated prostate cancer group. Additionally, the treated cohort was less likely to be Caucasian, but was better educated than the untreated prostate cancer group or the non-cancer groups. At the 12-month mark, 76% of the patients on therapy remained on treatment. While the rates of impaired performance did not differ between all groups at baselines, the hormonally treated group was more likely to demonstrate impaired performance than the control group within 6 and 12 months. The treated group was more likely to be impaired on greater than or equal to 2 tests within 12 months, with a p-value equal to 0.001. Of 383 single-chain polymorphisms measured, ultimately 15 were associated with changes in impaired cognitive performance. One variant, RS1047776, in GNB3 was highly associated. The rate of impaired cognitive performance decreased over time in the treated group with at least one A allele, either AA or AG. It more than doubled over time in the group of treated patients with wild-type GG. The patients on treatment with wild-type demonstrated higher odds of impaired cognitive performance within 12 months than those treated with at least one A allele. Age, baseline cognitive reserve, depression, fatigue, and hot flush interference did not moderate the impact of androgen deprivation therapy on changes in impaired cognitive performance. This study is among the largest controlled prospective longitudinal evaluations of cognitive functioning in prostate cancer patients treated with androgen deprivation therapy, and the first to report on the potential moderating role of genetic polymorphisms. The finding of the current specific polymorphism has been validated in only one other study. Other polymorphisms have been identified but will need further evaluation to be considered predictive for cognitive impact on those patients who were treated with androgen deprivation therapy. While the study limitations include its observational design and relatively small sample size, this information may be helpful in identifying patients who may be at greater risk of cognitive dysfunction at the time of initiation of hormonal therapy. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.